This is a status board. So the video you just watched focused on making your patient list, and that's one of the SCM views that you have, and the other one is a status board. So this first tab here is always your view, and it'll either say status board or patient list, and you can toggle back and forth between those two views just by the button underneath. So when I click on patient list, it takes me back to the patient lists I have. And when I click on status board, it takes me back to the status board. So when you first log into SCM and you have security access to the status board, your screen will look like this. So there's an option to pick your department and a view within the department. So you will only have a security access to the view of the department that you're currently scheduled or doing a clinical rotation in or hired into work. And if you're hired on more than one unit, you would have access to more than one view. So I'm going to do my demonstration on a level 6 view. So you'll click on the view of, or the department for level 6, and then within the views, there'll be all beds on side 1, all beds on side 2, and those would be the ones that you would see as nurses. On our medicine surgical units over the next few months, some of these are going to change as we add more columns on our status board, but we'll go through the basics right now. So I'm going to pick my view of all beds on side 1, which is going to show me a list of all the beds on side 1. So a status board is basically a communication tool, and it's like a big spreadsheet from Excel. So columns, rows, it sorts by the columns. So if we look at the bed, there's this tiny little gray sort of faded out triangle, and it's saying that right now all the information on this board is sorted out in order of the beds. And it's sorted out from the lowest number to the highest number. If you click in the gray bar at the top, the arrow will flip around, and now it's turned the sorting upside down. If I were to click in the column, the gray header column for patient, it would sort it out alphabetically by the patient's name. Most of the time, it makes most sense to have it in order of our beds. I like to show or demonstrate this because generally at some point you will inadvertently click in one of these gray header tabs and things will sort of look very wonky on the status board. And it just means, I always say, if things don't look right, go back to bed and just click in the bed column and resort by the beds. The information that shows up in these columns for our patients comes into SCM from a number of different ways. So initially, it comes in from the registration system. So when a patient is registered at the front desk, and if they're registered to one of our SCM using units where there's a status board, they'll show up on the board. Their name will appear, their age and gender, their visit reason, or which is their admitting diagnosis, who their attending physician is, and the room that they're assigned to initially. So those pieces of information automatically flow into SCM from registration. If there are lab results or x-ray results, the flags will show up on this new results column, and this is the same new results column that you would see on your patient list as well. So once there's a flag there, you can double click on it and it'll pop up with the information for the results that have just come back from the lab or from x-ray. If you want to view the details, this little image here will link you right to what we call PACS, or the picture archive, so where it actually views the x-rays. It's not often that as nursing we need to actually view the x-ray image. We're going to be more interested in looking at the radiologist report. And we always, and again, just that reminder of only look at the information you need to look at to provide care for your patient. Clicking on these plus or expansion symbols will link you and give you the radiology report. And when you're done with the alert on the new results column, you're going to want to click this button to clear the flag. So clearing the flag will take the flag out of the column, and then it leaves a blank square so you can get an alert for any other new results. You'll see in the next video I go through that the results are always available under this results tab. The flag is just the alert. So from our registration system, from the lab system, from the diagnostic imaging system. And then some of these columns have information that will carry into the columns right from your charting. So when we go through the chart notes, you'll see that you enter the isolation status on the admission note, as well as you can update it on a note that we call nursing daily care. The TLR status is also documented in a note and when they had their last shower or bath. So all of those pieces of information, the TLR, the isolation, they will flow right from your chart notes. And in those columns, if you were to double click on any of them, nothing happens. You can't change it on the status board. So those are ones you know come from chart notes. The other ones are manual. So things like the clinic list, if you double click, it gives a drop down. And most often it's the unit clerk that updates the clinic list based on who the attending physician is. The patient care coordinator or PCC is also a drop down. And from a nursing perspective, there's only two items on this column that are pertinent to nursing. So when you do a nursing admission, part of an admission is an ACAP screening tool. So there's questions like, are you currently receiving home care? Um, are you assessed for long-term care? And answering yes to those questions, there's 5 trigger questions, and a yes to any of those questions means that we need to involve our ACAP or our acute care, I can never remember what access program that stands for, to help coordinate our discharge planning. So if any of the trigger questions have a yes response, we'll do a referral to the ACAP program. So that's a phone call. And then on this column, we'll mark it as ACAP, meaning that we've sent a referral to ACAP. After that, ACAP will take over making any other adjustments on this column moving forward. If there's no trigger questions that are triggered, then the discharge coordination is nurse-led. And so then that column basically is changed. So those would be the only two things nursing would adjust on the PCC or patient care coordinator column, would be whether a referral's been sent to ACAP or whether the planning right now is by a nurse-led coordinating planning. When you go through the columns on the board, you'll see there's a scroll bar at the bottom. So not all the columns fit on one screen. And if you scroll to the end, you can't see who the patient is or what their room number is anymore. So it can be difficult to know who you're working with. You will see the patient's name up in the header, but it is nice to have the room number and patient name reference on the screen in front of you. So to do that, you can pick the column that you would like to have as your reference point. So I usually like to have the room and the name, so I'll go up to the patient column. You don't want to click normally in it or left click. You want to right click and lock that column. So normally you can see the words under the column headers. When we upgraded to 21.1, there were some glitches. I think it's fixed in our production or our live environment, but right now it's blacking them out, which is neither here nor there. If the first one's bad, the third one's patient. Once I've locked those columns though, now when I scroll, you'll see that the patient room number and their name continues to float on top of the list, and the other columns scroll underneath it, so you always have those room and patient name as reference point on the status board. So the main columns, I'll briefly go through all the columns, but I'm going to focus on the first 2 columns and look at those in a little bit more detail. The rest of them, because our columns are different on every unit. There's different columns based on a surgical unit, based on a neonatal intensive care unit, and vice all the way through. We're also moving to a different format called accountable care units, which have many, many more columns on them, but we'll also be able to print off handover reports at the end of a shift. So that means a lot less charting on those little team papers for report handover. So I'm not going to focus too much on all the individual columns. Those are basically for the units and the orientation on the specific units. But the first two columns, the patient or unlock these, the bed and the status, are ones that will have the most adjustments. So when a patient is registered to the unit, they will appear in the bed that they were assigned to with a status of pending in the registration system. The nurse column, which is the nurse who's caring for the patient, will be flashing yellow. When the nurse assigned to care for the patient selects her name off the list, the status will update of that patient to TIP or treatment in progress. So students' names won't be on the nurse list. It'll be the nurse that's in charge of the patient on the unit, and then you'll work as a co-person with that nurse. If the patient changes locations on the unit during their stay, then that doesn't happen at the registration level. That happens at the SCM level. Although we need to inform registration when we move them so that the two systems stay matched. So if this patient was going to move into one of these other rooms here, we would double click on the bed number and then it would pop up with a list of all the beds on both side 1 and side 2. So even though we're just looking at side 1 or hallway 1 in our view here, we can move the patient to hallway 2 as well. So if we were moving them into 605, I would just click on 605 here and the patient would then just appear on 605. And then we would need to let the registration desk know that this patient had been moved into a different room. As soon as the patient moved out of the room, it was flagged for housekeeping. So this takes me to our second column of statuses. There's 3 different main types of statuses. One is what we call an empty room status. Then there's a group of statuses that are patient care statuses, such as treatment in progress. And then we have something called discharge or disposition statuses. So I'm going to take a look at the empty room statuses here first. So when a patient is removed from any one of the rooms, it will automatically flag for housekeeping. So on the units, there are some of these status board screens on large TVs on the walls, and those alerts show up. So any personalized or medical information is not shown on those what we call public display boards, just alerts. So the room number's there, it'll just be patient initials, and then you would see if housekeeping was there, or if the doctor's name is in red because the status said the doctor's to reassess, or MD reassess the patient. If that's what the status is, the doctor's name highlights in red. So those alerts show up on those public display boards so that people walking past can see what they are. If the patient had been on isolation when they're discharged, so when they're removed from the room, it automatically flags to regular housekeeping. If I double click on this, you can see that I have a few other options. So the room can be ready to receive a patient. It can be waiting for housekeeping. It can be waiting for an isolation clean. An isolation clean CD, which stands for C. diff, so a specialized, or out of service. So perhaps the room needs some maintenance and we can't register any patients to it. So when they leave the room, it'll flag to regular housekeeping. If the patient had been on isolation, you'll need to double click on it and update it to an isolation clean. And that just changes the color so that housekeeping knows that they need to do a different type of cleaning. On the units, housekeeping staff is fairly stable, and our rooms that were isolation are fairly well labeled, so it will flag to regular housekeeping, and if we don't get to update this right away, housekeeping generally knows that an isolation clean is what is going to need to be done anyways. In the emergency department, where turnover is much faster and nobody would necessarily know, the room doesn't just go to regular housekeeping when a patient leaves it. It'll just flag as dirty, and then will have to be updated to either a regular housekeeping or a specified isolation cleaning. Once housekeeping has done the cleaning, they usually go to the desk and let the unit clerk know that the room is ready. Right now, housekeepers are not logging into SCM and updating it, so they will come in and mark the unit clerk or the nurse, whoever's at the desk, can mark the room as ready once the cleaning's been complete. In this list of rooms here under the bed, if you go down, our last room is 6111, and under that we see something called off service. And then there's code team and in charge. Code team and in charge are not actually locations or rooms, but we've put lines on the board there so that the nurse who is assigned to the code team can put her name on the board, as well as the charge nurse on the unit for the day. So at a glance, if there's people coming into the unit, onto the unit, who are looking to talk to the charge nurse, it's easy to find who the current charge nurse is, and then who's on code team, so everybody knows who's on code team if a code were to be called. The ones with an H beside them are called hallway beds, so those are overflow beds. Not specific locations on the unit, but when we have more patients than we have beds for on the unit, they can be in sunrooms or just in the hallway at times. So we do have these overflow locations as well. I want to focus a little bit on off service. Off service is a location where we will put patients who are still admitted to our unit but not physically on the unit. So if a patient leaves the unit either because they're transferred to another unit, transferred to another hospital, or discharged back to home, they should not be on the status board. But sometimes on our medicine units, we have an order where the patient will have a 72-hour pass to discharge. So they'll go home as a trial discharge, and we don't actually discharge them from the system. So there's enough of a potential that they might come back into the hospital, not be able to be successful with the home discharge. So we'll send them home on this trial. So they'll go home, we don't discharge them. That way, if they need to come back, they don't have to go through the whole process of finding and attending to accept them and all the red tape of a registration. However, we're usually very, very tight for beds, and so we don't actually just make the bed and leave it empty. We will register another patient to that bed. So we'll take that patient who's going on that pass to discharge and move them down into off service. And you'll see as I scroll through this list of beds that there's an off service after bed 611. And if I scroll through side 2, there's also an off service after bed 635. So there's an off service location in hallway 1 and an off service location on hallway 2. So when you're moving a patient, if they all of a sudden disappear from the screen in front of you, you just generally have to change your view to the other hallway. So if I'm going to move this patient down into off service, then they're down here. So this should only be used when the patient is still registered to the unit but not physically staying on the unit. The other time you might need to put someone in off service is if there's a registration coming from the emergency department. So we might have Mr. Smith down in the emergency department who needs to be admitted to our unit. And this Dill Chip here, Mr. Chip Dill, is going to be discharged today. So our supervisor who's looking to find a bed to put Mr. Smith in sees that Mr. Chip is going to be discharged today. So she tells the registration desk, Mr. Smith is going to go into bed 6051. Mr. Chip is still waiting for his family to come and give him a ride. He still needs his dressing changed, and he still has to get some medications sorted out from pharmacy. So he's not leaving for a couple hours yet, but if registration admits Mr. Smith into bed 605, it's going to put 2 605 bed 1s up on the board here. So while Mr. Smith is actually registered to our unit, he's not physically there yet. He's still down in the emergency department, so you would take and put him in off service as well until Mr. Chip was discharged and his room was cleaned. If we leave Mr. Smith in the same bed showing on the board here, then when we discharge Mr. Chip, it's not going to flag the bed to be cleaned by housekeeping because there's already showing that there's another patient in there. So if the patient's registered but not on the unit, we can put them down in off service. And then when Mr. Chip goes home, the bed is cleaned and Mr. Smith comes up from the emergency department, then we would click on his off service location and move him into his new bed. So those were the empty bed discharges or statuses. Ready, housekeeping, isolation clean, C. diff, or an out of service, meaning that we just can't use the room for a patient right now. The next group of statuses we'll take a look at are patient statuses. So the patient statuses and the discharge statuses are all on the same list. So some of them are communicating about the patient, what's happening, what we need to happen while they're still registered to our unit or what the plan is. So when they're registered, they show up as pending. When the nurse assigns herself to the patient on the status board, they upgrade to treatment in progress. Then if we want a physician to reassess them, since we've switched to the hospitalist program, we don't use this one as often because the physicians are on the units following the patients more closely rather than when we were waiting for a family physician to show up after clinic hours. The physician to reassess was something that we used to remind us and the doctor that there was something in the chart we needed them to look at for this patient. But if there's ever a time where we need that alert for the physician, you just change it to MRP reassess, most responsible physician to reassess, and that changes the physician name to red. After they come up and they've seen the patient and they've made any notes in the chart or orders, then we would change it back to treatment in progress again. When a patient is going to be discharged today, and we've got the discharge order written, it's updated to a pending discharge. This will put the nurse's name in a green alert, and that lets the nurse know that the discharge order has been written. It's in the chart, and so whatever coordination is left to be done for discharge can be moved forward with. Waiting for transport, when that one's selected, it puts a little ambulance icon up beside the patient's name, and that indicates that the patient is going to be transferred to another acute care facility. So that could be a higher level of acuity if we're sending them to Saskatoon, or perhaps PA was the higher level of acuity and now they're going to go back closer to home to recover. So waiting for transport means that today they'll be transferred to another acute care facility and we're just waiting for the transport. They don't necessarily have to be transported by ambulance. Sometimes families can arrange the transportation. The ambulance is the symbol that we use to indicate or have that alert up there that this patient's going to be transferred to another acute care facility. Awaiting unit transfer means that this patient's going to go to another unit. So perhaps we have a patient on level 4, had surgery. They've recovered from their surgery. They're not a surgical patient anymore, but they still have some medical issues. So they basically are a medicine patient now, and we want to transfer them to one of our medical units off the surgical unit. We don't select awaiting unit transfer till we know we're going to have a bed available on the other unit. And again, we have to remember these statuses are all about our patient is still on our unit, they're still registered to our unit. This is the plans that are going to happen or we're planning to happen in the near future. So the communication of our admitted patients. So pending treatment in progress, physician to reassess, pending discharge, waiting for transport, awaiting unit transfer. And then there's a pass. which is a short. Then there's that pass to discharge, which is the longer one I was talking about. So it can be a 48-hour or 72-hour pass to discharge. If the patient goes down into off service on their 72-hour pass to discharge and they don't come back after that 72 hours, then we consider their time of discharge to be when they left on their pass, and then they'll get removed from the status board. ALC internal is our last admitted patient status. ALC stands for alternate level of care, and that basically means we have a patient who's in the hospital, but they no longer need hospital services, but we don't have a place in the community yet that can accept them or take care of them either. So that is most often when people are assessed for a long-term care facility and there's no beds available in long-term care facilities. So they get removed or they get changed from an acute care patient to an alternate level of care patient. And this is very much about sort of tracking data, because the government is finding that, we've got these backlogs in our emergency department because we've got people in the emergency department who are waiting for a bed on an inpatient unit. We've got no beds on the inpatient unit because we've got people on our inpatient unit who are waiting for beds in a long-term care facility. So it helps them track that and know where they need to invest money, either for more long-term care beds or other situations as well, so that we can keep people moving through the system. So alternate level of care internal means they become that alternate level of care status. They actually begin to contribute a small portion financially to their stay in the hospital, and it means they're also going to stay within our facility on our unit. Sometimes we transfer them off our unit when they become, or out of our facility when they're alternate level of care, but that would not be an active or admitted patient status. That would be a discharge or disposition. So up to alternate level of care on our inpatient units is still an admitted status. Below that are discharge statuses. And again, these statuses can differ from unit to unit as well. The emergency department has many different statuses compared to our inpatient units. Any of these other statuses below the admitted patient ones, you'll get a pop-up that asks if you want to remove the patient from the status board because they're leaving the department. So you'll pick discharged if they are leaving and going home or back to the same place they came from. So if they came from home and are going back home, they're just discharged. If they came from a long-term care facility and are returning to that long-term care facility, they're just discharged. If they're discharged on pass, that would mean before you discharge them this way, prior to that, they would have had an admission status of pass to discharge. So they were on the pass to discharge. They're probably down in off service. They don't come back from this pass to discharge, so you would discharge them on pass. Unit transfer, they would have had an inpatient status of awaiting unit transfer. Then when they actually transfer off to the other unit, they would be discharged with a unit transfer. If they had a status of waiting for transport because we were planning on sending them to another acute care facility, when they leave the building, they are discharged as a transfer acute. You might go, why does it matter if I pick a specific discharge or disposition status? Why can't they're just discharged? Why can't I just discharge them? This a lot also comes back to data collection. Well, the ministry will often, they'll put out, can you give me the data on how many people were discharged from your hospital to another acute care facility in the last 6 months? And it gets very, very difficult to find that information if we have to go and read through 450 paper charts. Whereas if we make these clicks on our status board in the computer, we very quickly can pull that data. And data is only as accurate as the person making the clicks. So I encourage you to, conscientiously make those choices. My past experience with data collection in nursing has been usually if somebody wanted to collect data, it meant we had to fill out 6 extra forms, and we didn't do a very good job of it. I can tolerate choosing what I'm clicking on if it helps collect that data, which helps inform our government and where they send their money at times. Long-term care and personal or private care home are only selected if they are new destinations. So they came from their sister's home or their daughter's home or their own home when they came to hospital, but when they leave, they're moving into a long-term care private home. That's when we select those. If they had come from that long-term care home and are going back, then it would just be discharged. Then we have our alternate level of care external. And that is when we move them to that alternate level of care status, but sometimes they go to a step down hospital. So sometimes our more rural hospitals have a few more beds available than our tertiary hospital in Prince Albert, and so we might move them out to Shelburne to wait until there is a long-term care bed available. So that's when we would actually do a discharge status of alternate level of care. If they have passed away while on the unit, then we would remove them from the status board as deceased. We don't click on that and leave them on the status board because that status does display on our public boards. We do have another way of marking our rooms where we have a deceased patient that's still on the unit. But this deceased status is only used when the patient has actually got on the elevator. Left against medical advice, pretty self-explanatory. Absent without leave, they went out for some fresh air and never returned. And then canceled is used when a patient is registered to the unit in error. So the registration desk registers them to our unit, but then they end up going to ICU. Then we have to remove them from our status board with canceled. If a patient's being transferred to another unit, we have to make sure that there's 2 pieces that are done in order for them to show up on the status board in the other unit. And part of that is registration. So if our patient is going to go to ICU from our level 6, the registration desk has to be notified and they have to do that transfer in the registration system. So for Prince Albert, our registration system is called WinKISS. And if they do that transfer in the registration system, underneath the patient's name in the header, it will update to the patient's new unit location. So this would update to VH ICU and whatever bed they were in. However, even though it's been updated in the registration system, we would still see the patient on our level 6 status board and they would not see the patient in ICU. So in order for them to see the patient in ICU, we also have to remove them from our status board. So if they updated in registration and it's updated here, then when they leave the unit, I would go to my transferred with a unit transfer. Then it says verify that this patient you intend to remove from the correct view is this correct patient as a unit transfer. And if it is, I'll say okay, and they're gone. And they would immediately show up on ICU's board. If someone forgot to call registration and I did a unit transfer on the status board, then my patient is going to sit in something called inactive patients. So they're going to sit in this list here until the registration part is done as well. So if you have removed the patient from your status board as a unit transfer and ICU is saying, I don't see the patient on my board, you have to say, ooh, right, we have to let registration know. And then if registration does the change in registration, this list refreshes every 15 minutes, so 9, 9:15, 9:30, 9:45, and the patient would go to the unit then, or you could right click on them and remove the patient. We don't have an option here because the patient hasn't been transferred, but you would be able to remove the patient and they would go right to the ICU board. So you can either wait for that 15-minute refresh and then they'll be there, or you can remove them from the board yourself. If you discharged a person unintentionally and you didn't mean to, or they were the wrong patient, You can return them by coming to the inactive patients, right-clicking, and return patient. They will pop up, return them to the selected location, so that will be the last room they were registered in or were on the status board. Say OK, they disappear from our inactive patients. We can go back to our view of all bedside 1, and they're back in their room, and then we would just need to update their status to treatment in progress. So that's the bed column and the status column. Those two columns kind of have the most changes, where you would adjust things or you have to update things, or they create alerts on the board. So the discharge, pending discharge, alerts the name nurse in green. MRP to reassess alerts the physician in red. Some of the icons that you will see beside the patient name, those are also alerts. So if you see the star, that means the patient is a fall risk. When we admit all our patients to our medical and surgical units, they automatically will have that star there. So we're saying we'll treat them as a fall risk until we assess them and find out they're different. And when you do the nursing admission, one of the questions on there is this patient a fall risk? If you select no on the nursing admission, the star will disappear. If their status changes during their stay, there's a document that you will be doing every day called the Nursing Daily Care document. And when you do that one on there, it will ask, that'll be done every shift. And if you say yes, a fall risk, the star will show up. This little stick man here who looks red, and if he was bigger, you would see that he has a glowing yellow outline. We call him Itchy Scratchy Man, and that tells you your patient has allergies. So when you fill out your nursing admission assessment, there's a question on there about allergies. If yes is selected, that the patient has allergies, then this icon alert will show up beside their name. Some of the other ones, you saw the little ambulance that popped up when the patient was going to be transferred to another acute care facility. This little caution symbol here indicates that the patient is an aggression or violence alert. So some of the alerts that we have pop up here are these last 3 columns that are check boxes. So there is a violence alert screening tool on all the units. So if somebody has a potential for violence or aggression, that tool will create a score. And if the score is in that criteria, then this box gets checked beside the patient's name. And if it's checked, the alert symbol will appear beside the patient's name. If it's unchecked, the alert symbol will not be there. I mentioned before that we had a way of alerting, so when a patient passes away and the body is still on the unit and the family members may still be with the patient, we want to mark that room so that, dietary knows they don't have to go in and deliver the tray, lab knows they don't have to go in and draw the blood. So we hang a picture of a rose on the door, and we also hang a picture of the rose up beside the patient's name on the status board. So we don't want to change our status to deceased. We want to just hang our rose on their door as well as up by their name. And that just creates that communication tool. And if we have a palliative patient in our palliative program, that's what the P column stands for. So P equals palliative, which also equals purple. So we have the purple ball indicating our palliative clients. One of the other icons that we have is it looks like if you're familiar with little Lego people, the top half of a Lego person is what it looks like. And that is if the patient is under the age of 6. So a pediatric patient under the age of 6. We won't typically see that on our medicine or med-surg units. We will see it in the emergency room though. And there are new icons coming in the near future, sometime in March probably. The other columns are quite self-explanatory. So code status is another one that comes from your charting. Visit reason comes from registration. Nurse is a drop-down. New results is flags from when lab or diagnostic imaging results are released. MRP, most responsible physician, that comes from registration. Clinic list is a manual drop-down. TLR from chart notes, PCC is a drop down, D minus is a drop down, the barriers to discharge. D minus stands for days to discharge. So if we're targeting discharge in 3 days and we have no barriers, it's green. If we have some barrier that we need to take care of, then it'll be orange. Comments is free text, and you can put a lot more in than what you can see. And any time in SCM where there's more information than what you can see, if you just put your mouse over top of the area, you don't have to click, you just have to put your mouse over. It'll pop out with what I call a shadow box and give you the full content of the field. And that is anywhere in SCM that works. If you can't see everything, just put your mouse over top of it. Diet is a drop down. The COVID screening is a drop down. COVID swab is a drop down. Last swab collected, those are date ones. Flu vaccine is a drop down. Isolation comes from charting. Your last shower comes from charting, and then your check boxes. And again, a surgical unit has other columns related to dressings and mobility post-op that we don't see on our medical units. So if you have any questions about your status boards, you can ask your preceptor or any other staff on the unit, and they should be able to help you. Any questions about the status board? So basically you can flip back and forth between status board and patient list views, and there's benefits to using both of those views as you're working through your patient care for the day. You can pick your department that you're going to look at your status board for, and then your view of that within that department. And that pretty much sums up the status board.